Our next speaker is Dr. Albert Murati. For the first year or so that I worked with this character, I called him Moriarty. And he finally came up to me and said, "Do you think this is a Sherlock Holmes episode?" And he said, "It's Murati." So I will try to say that name correctly through the rest of the night, but I can't guarantee any of that. Also, Al brings to anesthesia, I'm an anesthesiologist, some of the scariest cases that anesthesiologists have to face. Thank you, Albert, for that. He's an associate professor of otolaryngology and head and neck surgery. He's the chief of the laryngology service, and he's an expert on throat diseases, voice disorders, upper airway problems, tumors growing out of everything that we have to try to manage somehow with our endotracheal tubes. He's a specialist in airway diseases, upper airway diseases, throat diseases, and voice and vocal cord paralysis. He actually went to medical school here at the University of Washington, and then did an internship in general surgery and residency at UCSD, and then did a fellowship in voice at Vanderbilt in Nashville. He's the president and co-founder of the Northwest chapter of the Voice Foundation, which is a nonprofit organization looking at the medicine, science, and education around the voice. Very cool foundation. In his former life, I'm going to show this next one, he was a lead guitar player in a band. You guys should get together, because you played guitar too. But they're both lead guitar players. I played the bass, and that really is the engine to a band. But the leads are kind of a dime a dozen, I think. Anyway, he's a lead guitar player and did some night club gigs in Ankara, Turkey. He is an avid or maybe fearsome poker player, and Texas Hold'em is his game. He's joined again in Seattle with his wife, Jennifer, and he has a son, Solomon, who's 20 months old. You are going to love this guy. And here is the human voice and Dr. Albert Murati.
Well, it is certainly a privilege to be here. I think a greater privilege would be knowing which button to press next. All right, I did this just for you. Ready? Clear picture? Mm-hmm. Well, welcome to the Mini Medical School. My name is Al Murati, and this is my larynx. This is my larynx laughing. This is my larynx saying E. E. My vocal cords are vibrating really fast. This machine allows me to see the rapid vibration of the vocal folds. E. The larynx is an elegant organ which controls voice, swallowing, and airway regulation. Hope today's session helps you appreciate it as much as I do. I look forward to speaking with you. I might skip the first 5 minutes of the proctology talk. What are we doing here? We've gone from sort of the sublime maybe to a different sort of elegant. You know, I always say the ear doctors are a higher form of life because they make people listen and we just make people talk more. But I think it's important. It matters to each of us. I mean, many of you, pleasure of singing, communication aside, many of you work with your voices. How many of you couldn't do your job without your voice tomorrow? How many of you could? How many of you have never raised your hand? All right, can't say that again now. This is a singer.
All right, good. Stop. Okay, let's just do a middle E again. E.
Right near the break, perfect. Keep it up. She has this bump on her vocal cord. We're going to talk all about this. Stay on that. More sound on the video, please.
Good. Drop your pitch a note or two.
Stay on that. Stay on that. Stay on that. She sounds okay here, but she's breaking.
Okay. Great. Stop. Okay.
Yeah.
Good.
Try to draw it out longer. Let all the air out. That was a good one. That was good. Let all the air out. Try to make a little noise with it on the way in. And you can see that bump. Out. That was really good. That was your best hit. Can you do it again? That little 1.5 to 2 millimeter bump is keeping her and her band from touring, from singing. Whether or not you're a telemarketer, not necessarily everyone's favorite profession, or a lawyer, teacher. Teachers are our biggest group of patients. A 2 millimeter bump on your vocal cord can change what you do. I put this penny on here as a rough gauge of how big this is. What I want to do is get that cracking voice to this. This is post-op. Good. A little higher. Nice wave. Just a tinge of pink through there. Now, what do you make of this sort of...
Okay.
That's pretty cool. So that's just about a month post-op. So she's got more and more healing to do. So this is what we're doing here. We're talking about the elegant function of the vibration of the vocal cords. We're going to talk about how the vocal cords meet, how they work, what drives them, the bumps and lumps on the vocal cords, a sort of a connection of the medical terminology that we use every day with some of the colloquial terms that are close to being correct, but I want to get you to where we all agree on some of these things you've heard of, nodules, cysts, polyps, things like that. I have nothing to disclose or declare in terms of the any financials. I did think of something when I heard I was going to be in Hoganist, because I was sitting in that chair, a gentleman with a red shirt, in June of '89, not that I remember it exactly, and that's when I thought I'm going to have to do something else, because I didn't remember anything about my kidney final exam, which was in that chair. I know that chair, sir, and I'm going to think about that. And I got about, when you're taking an exam and you kind of know some of the stuff, and I was a pretty good student, and I got about 5 questions in, nada, crickets, airball, nothing. And I left, I walked out, gathered my thoughts out there, considered my options, including rock and roll, and decided to come back in and did pass the exam. But when I thought about that, I thought about the phases of each of our careers we go through. And I thought about one of the great philosophers, I think, great philosophers of the last century, taught me something when we think about what phases we go through, because it's kind of cool to be up here giving a talk, etc., after having been in that chair. So I'm talking about Ricardo Montalban. So the 5 stages of Ricardo Montalban, because it applies to each of our lives. In our careers, we get asked, people ask about us, who is Ricardo Montalban? Then the next phase of our lives, get me Ricardo Montalban. Then, of course, get me a Ricardo Montalban type. Get me somebody like Ricardo Montalban, because he's too busy, we can't get him. Then, of course, we transition, get me a young Ricardo Montalban, or the Ross phase. And then finally, who is Ricardo Montalban? So now I don't know quite where I am or if I'm even on this, but now that I've gone from the chair to the podium, it's a privilege to be here. My lovely wife let me be here tonight, and my little dude. Yeah, he's super cute. Come on, give me a break. So what are we going to talk about? We're going to talk about how does the voice work. We're going to talk about what can go wrong, some of the common maladies that affect the voice. What are some of the basic tools we have to treat vocal problems? And then, how do we take care of our voices, each of us as individuals, and how do we help counsel people to take care of their voices? Let's do this little important part first. Because frankly, if there weren't these sort of behaviors that lead to vocal trouble, that are choices that we all make, I wouldn't have a job. Let's address this first. The big 3 are alcohol, tobacco, and caffeine, or as we call it in clinic, alcohol, tobacco, and firearms. But without these three, I mean, there would be a fraction of vocal disorders. Inadequate hydration, water, comes down to one of the major issues affecting voice in terms of day-to-day vocal production, vocal issues and maladies affecting the voice. It didn't necessarily cause the problem, but it is one of the things that's in the way of each of our patients getting better. People will fly from Alaska to see our terrific team for expert consultation, and often I spend 15 minutes, 20 minutes talking to them about hydration and not drinking 2 pots of coffee, and things like that. We do it in a supportive way. They've seen 18 doctors, all of whom said the same thing. But when you fly in and you get told this, at the referral center, it's perhaps a bit convincing. Vocal abuse, misuse, and overuse, which are slightly different things. I can never remember what each of them exactly are. But overuse is doing okay stuff with your voice, but just doing it too much. So this is someone who has a busy, they're reading an audiobook professionally, or they're speaking in normal voices, but they're doing it for 42 hours in a row. Vocal abuse, those are people who are yelling and screaming, the stock traders, people doing character voices, things like that. Misuse, I can never quite tell the difference between that, but these are some of the potholes that people fall into with their voices. And each of you have been there, screaming at the Husky game, or calling for the dog that didn't come back, etc. These things happen. If I can get people not to do these things, I will just go ahead and retire early. So how does the voice work? You saw that cool video of that super singer singing Happy Birthday. So we're going to talk about the gross motion, how the vocal cords come together, and then how they vibrate, because that's where the magic is. This is the obligatory gross surgery slide that I'm mandatorily have to include. This is the voice box or larynx. Please, 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 thank you for calling it larynx and not larynx, because that makes me cry when people do that. Just remember, it's laryngitis, not laryngitis. So the larynx is the larynx. It's okay to call it larynx. I'm kind of kidding, but I hope you do call it larynx. It sits low down in the throat. It's the Adam's apple in men, and women have Adam's apples as well. Eve's apples, I don't know what we call them, but they're less prominent. And they sit down in the throat, and it sits at the top of your windpipe. It regulates all the air going in and out of your lungs. That's what it really does. We casually call it the voice box, but the voice, as elegant as it is still only a part of what it does. It controls all your airflow. If you get a piece of the Frankfurter stuck in the old larynx, you're not going to breathe well, and you're not so worried about making voice because you can't breathe. Intertwined with this is its role in swallowing, and we're going to talk about that. Here's the voice box as a whole. The vocal cords, which you saw so elegantly in that song, are just these 2 little stripes right here, each about a centimeter or so in length. The structure of the voice box from the outside, it's attached to the hyoid bone, which is a U-shaped bone that sort of mirrors or echoes the jawbone, but lower in a small way. The thyroid cartilage, which is, thyroid just means shield-shaped. It's shaped like a shield. Now the thyroid gland, which many of you are familiar with, is just below this. The thyroid cartilage is right here. And then the cricoid cartilage just below it. The larynx, as I mentioned, is responsible for airway, so it controls, protects the airway. When people go into spasm, their throat spasms up, they can't breathe. When people have tumors or problems with their larynx, scars, blockages, and they can't breathe, they get what you may have heard of, a tracheotomy, or even something, many of you have also heard of a cricothyrotomy. These are to bypass the blockage because the larynx is responsible to manage and regulate the airway. Deglutition is a $75 word for swallowing, and it is one of the most elegant functions that the larynx has. You can't swallow 98% correctly. You all know what it's like to have a drop of water or a little bit of a crumb of a cookie go into your throat. You cough for a while. Can you imagine if you have 3,000 cc's of intake a day and you swallow 99% correctly? That is, please help me somebody, 30 cc's going down the wrong way. That's a lot. you will get in trouble. Everybody aspirates, stuff going down the wrong way a little bit, but it's really microscopic in most healthy people. This is a key function of the larynx. We're going to spend our time talking about phonation, which is the production of voice. The larynx is also critical for tree climbing. And this is one of the reasons, because of the way the cow's larynx is shaped, why you don't see cows in trees. But that's extra credit. You have to sit through the proctology part for that. Now, how does the larynx work? We're going to talk about two broad concepts. Motion, meaning the vocal cords moving to put the cords in a certain geometric position. Then once they're in a certain position, how they get vibrated by the air. An important concept is that the voice box, the larynx, is driven by essentially two nerves that run out of the brain, down the neck, and through what can only be described as a fairly cool thing in anatomy. They take a U-turn down here in the chest. Here's this blue nerve coming down the neck. And for example, on the left side, it takes a U-turn around the aorta, the big blood vessel coming out of the heart, and goes back up to the voice box. It recurs back up. And we call that the recurrent laryngeal nerve. Why does this matter? If you have emergency aortic surgery, when that skilled thoracic surgeon is saving your life, one of the byproducts of that, which we can deal with, is that the vocal cord goes on that side. If you have a chest tumor, if you have a lung cancer, your vocal cord can get affected because of disease or of cancer in the chest eating into that nerve. The problem can be far away from the voice box and still cause vocal problems. So this nerve is responsible for driving the vocal cord to be in position. The vibration, which you saw during that song, that oscillation of the vocal cords, happens because of the airflow. The larynx has a system of muscles that open and close the vocal cords. When they abduct, they open. You can think of abduct as sort of running away with something. You open up. And adduct is to add together. They close to put the vocal cords in position. Here is an image of the vocal cords. This is a still. You saw the videos earlier. This part from here to here we refer to as the phonatory, phonation being the term for vibration of the vocal cords, or voice. This part is the part that vibrates. The part on the back is where most of the air goes through. Now, just to orient you in your body, this is a picture looking down at the vocal cords. The way to remember this is this point in the front where the vocal cords come together, the V, interestingly, for voice. The V in the front corresponds to the prow in the front of your voice box. So these are parallel to the floor. So the vocal cords sit like this in each of us. And they close. Most of the pictures, obviously, are going to be like this or like this because of the screen, but that's an orientation I think that'll be helpful for each of us. Normal voice production, and in post-production, we'd like to insert a video here at this spot. Normal voice production involves vibration of the layers of these vocal folds. In this image over here, this is one vocal cord cut in cross-section, and it has 5 layers. This thin black line is the epithelium. The deeper tissue is the muscle, just like muscle anywhere else in the body. What makes the vocal cord magic is these layers right below the epithelium that have basically a jelly-like substance that allows for the epithelium, the lining, to vibrate over the underlying structure. And this can be seen in this video. For each of you, I'd like you to take a second to vibrate your vocal cords in the following way. You need 3 things to make sound. You need power, so air from the lungs. You need something to vibrate, that's the vocal cords. And then you need the vocal tract to resonate. If I, theoretically, cut somebody's head off right at the voice box and had just their vocal cords vibrating, they would sound like a little kazoo. They just would sound But it takes the resonating chambers of the head to give us our rich sounds, especially if we're trying to do the fake FM voice. which comes up and talks somehow. So when we're making sound, I can ask you, let's have everyone do an F and then kick it to a V. Okay, all right, now wipe the hair off from the person in front of you. So that F, so it's the same airflow, you didn't move your articulators, right? The sound shapers in your lips, teeth, tongue, etc. All that happened is your vocal cords kicked in. You phonated, just like an S to a Z. Zzz. Okay, good. So that's voice. Now, how you get from there to like a magical singer is a whole different art. How does it work? When you have the vocal cords together, now this is a front shot. It's a coronal section, a term which means you're looking at the vocal cords as though they were cut in this plane. So the pictures we saw from above would be coming down onto this picture. This is a slow motion cycle, it's a cartoon of the vocal cords going through each step. The air builds up below the vocal cords. They pop open microscopically. They're not open far apart. They're just popping open just a little bit. Then that little gap allows for some air to escape. That creates a little bit of low pressure right in that area between the vocal folds, that the jet sucks the vocal cords back together again and creates kind of an equilibrium between the pressure from below and that little jet goes over and over again. If you sing standard middle C, that's 256 hertz, 256 times a minute. So that happens quite fast. Now, the vocal cords are interesting because you've got every note in the piano on your keyboard. Excuse me, every note on the keyboard in your throat is what I was trying to say. Your vocal cord isn't just a windshield wiper opening and closing like this. It can change its conformation to be stubby, shaped like a football, or it can be a very long, you saw in that introduction that I did, when I went my cords got very long and thin. So they can change their conformation and become any note on the piano. Now some people have a few more notes than others, but in terms of the vocal cords, they don't just open and close, they change their shape. You need to have full closure to have a good voice. So when there's a weak vocal cord, remember that nerve that goes down in the chest and comes back? I'll show you an example a little bit later of someone who had a paralyzed nerve and couldn't close his vocal folds. So if your cords aren't coming together, you can't have that diagram that's where you have that cycle of contact. And people just leak air. They can't talk anymore. They lose all their lung volume in one syllable. And they're super frustrated. And it's treatable. You need full vocal cord closure to have a good voice. You have to have symmetry of vibration to have a good voice. You can't have a bump on one side. Now, if you have swelling on both sides, you can have a pretty good voice because even though it's a heavy sound, right, because the cords are vibrating, if they have extra fluid on them, they're weighed down. So it takes more oomph to talk. So when your cords are a little sore from having a cold, you can still kind of push your voice out the next day. Not that it's good for you, but you can do it. But it's an effort because you're vibrating those heavier cords that weigh more. Finally, there has to be an efficiency of vibration, so there can't be scar. That very specialized gooey layer under the epithelium has to be just so. If it becomes scarred by something a doctor does, by a tube down the throat, by smoking, by acid reflux, for example, all these things can cause damage. How do we evaluate patients when they come see us? We talk to them, and then we look down their throat. It's really about it. There aren't very many x-rays. There aren't really hardly any lab tests that help us. We ask them, is it worse with voice use? Is it better if you rest your voice? This is sort of the typical, almost always new teacher. You know, we don't see people who've been teaching for 20 years have sudden voice problems unless something's growing on their cord that's new, or they've changed their voice responsibilities. They've taken on a group of special ed assignments, or they have a different classroom environment, or they have a high discipline ratio in their class. The occupational issues related to teachers' voices is a massive occupational health issue in this country. And it's interesting. Not only are we talking about sick days and loss of continuity in the classroom, there was an elegant study done where they did lessons with teachers with rough voices compared to teachers with normal voices, and the kids learned better from clearer sounding clearer voiced teachers. So there may even be some drop off in the educational delivery there. We asked them about previous histories of hoarseness. Family history, not so helpful. There aren't a lot of familial voice disorders. And then we asked them for pain or discomfort. What's interesting is how the voice box is sort of at the intersection of all these different areas. Lung problems affect the voice. Reflux is a classic problem that affects the voice. Acid reflux is a term you're all familiar with. You know, all the ads on TV and all these drugs and Tums and Prevacid and whatnot can affect are used to control acid reflux. We ask about these things. We ask about, have they ever had a tube down their throat that may have caused some damage? Now, when there's been life-saving medicine and someone's been saved in the ICU after an injury, you know, we accept and deal, of course, with these problems. These are not bad things that happen, but they're byproducts of life-saving medicine occasionally. The menstrual cycle can affect the voice. Just like patients have a premenstrual syndrome, they can have a premenstrual voice syndrome. The same hormones that affect the engorgement and changes in the the blood vessels within the vocal folds and the retention of fluid can affect the vocal cords. We will, not often, but occasionally see female performers who know when to take time off because they happen to be quite affected by the weight on the vocal folds, and occasionally the fragility of the blood vessels. And occasionally we have to put patients on medication to regulate their cycle, of course, if this is what they wish, in terms of reducing the unpredictability and variability of their voice. And then reflux is sort of the gorilla in the room in terms of the most common medical problem affecting the voice. This picture, I'm not sure if the color shows up, but that's green. There aren't a lot of green things in the body. One of them is bile. So I'm operating on this lady, and all of a sudden, you know, she's asleep, but I noticed this juice coming out of her esophagus, sitting on her vocal cords. And I looked at the resident and said, that is bile, because there aren't a lot of green things in the body. That could be one of our take-home points for the day. So this is something that I think is interesting because reflux is common. We talk about acid reflux a lot because acid reflux is common. There's great debate about why patients don't necessarily get better on certain types of reflux treatments and whether or not surgery is a good idea. Generally it is if you're seeing a careful surgeon. But this is non-acidic reflux affecting the larynx. This is from a colleague of mine in Milwaukee who was able to show that pepsin, which is the principal digestive enzyme from the stomach, gets into the lining, the epithelium of the larynx. And we can show that it's actively uptaken. It's not just that you erp up some juices and it digs away at your throat. If it's in your throat, your body has a molecule that sits on the lining of the throat that actively takes it in, and it wreaks havoc and can cause, we believe, some destruction. I don't bring it up because it's the big thing going on. I bring it up because it's a new area. And I wanted to share with you some of these things because one of the treatments potentially for this has to do with algae. And in addition to all the drugs that people, I think, in generally take in a helpful manner to fight reflux, algae or alginate treatment, alginate is the derivative from this brown algae that's made, will be something that we hear about more and more in the future. So kind of an interesting aside, these are the medical issues that we talk about. When we treat when we treat voice problems, we only have 4 tools. We have got time, right? Some things will get better. We have medications. Often they're things like anti-reflux treatment. We have voice therapy, and then we have surgery. Those are the big categories, generally speaking. I was at a conference in Florida, and I was walking with my fiance at the time, now my wife, and I saw this poor resident asleep, and I was walking from behind him. And I saw the book was open to some vocal cords. I said, "Oh my God, no wonder he's asleep. He's reading a laryngology or voice medicine book." Then I circled around and realized it was my book. And he was out like a light. This is a true story. So I kind of nodded at his buddy there to see if it was okay to take his picture. I did subsequently follow up with him and ask his permission to take the picture. And yes, so that's what you have when you get a book out there. So how do medications affect the voice? Well, like the old adage, if you want to look for the problem, look for the footsteps of the doctors. Much of what we do in medicine is miraculous, lovely, etc., but we do things that have negative effects on people. And sometimes they're agreed to things. We know they're going to be negative effects, but sometimes we're not aware. The most common medication effects that have deleterious or negative effects on the voice have to do with the inhalers that many people take for asthma or emphysema. And also there's some systemic drugs. A good rule, the most common thing that drugs cause in terms of negative impact on the voice is by causing relative dehydration, by causing water loss, by being a diuretic, etc. There are very few direct effects of medications on the voice. There are some positive effects. Parkinson's, for example, 30% of patients with Parkinson's, at least in the early stages, describe their communication issues as their dominant complaint, more so than their social isolation, which comes from it, because they can still communicate within the family, but more so than their motor changes, their ability to move around. If you treat a patient with Parkinson's medically with their Parkinson's drugs, their voices actually improve. So there are some indirect treatments that can affect the voice in a medical standpoint. Remember, the only tools we have are medication, therapy, surgery, and time. Hormones can affect the voice. We gave you an example of the premenstrual voice syndrome. We see this sometimes with hormonal manipulation of tumors. One of the treatments has been, I'm not up to date on this, but for prostate cancer has been hormone manipulation in males. And we see patients get vocal fold swelling and edema and go through changes we see occasionally in women in a male larynx. One of the toughest things we see, it's not common at all, but it can be devastating, is women who take, knowingly or unknowingly, male hormone. Now, so this is something that can be prescribed for, including for things like libido. And unfortunately, male hormone in a female larynx can cause irreversible changes, masculinization of the voice. It's not predictable, it doesn't happen to everybody. Many patients get very positive, important results from these things. And they may agree to this following an informed discussion. Unfortunately, rarely people aren't given that information. I'm not at all saying it's not a good idea, just it has to be done in an open way. I can't fix it. And people will come in, singers will come in, and they'll say, well, yes, I was given this hormone, for this, that, and the other reason. I just can't hit my notes anymore. I can't fix that. So how do we look at the larynx, and then how do we treat it? And we'll wrap up after that. We look at the larynx with a scope. You saw that video image of a scope going perched over my voice box. That's done through the nose. It's not entirely pleasant. I tell the patients I wish I had X-ray vision, but I don't. And I look at their larynx that way. There's also a scope that can go through the mouth. That's this rigid scope here. Some patients like one, some patients like another. They're both excellent. The strobe, just like the strobe in the disco, because when the strobe's on, everybody's a great dancer. Even you are a great dancer, because God knows it helps me. But the strobe is our main tool for looking at the voice box. Remember how I said the vocal cords are vibrating hundreds of times rapidly? The problem is I can't see that. I can't slow that down to see that. So we use the strobe light get an optical illusion of the natural vibration of the vocal folds. And we'll show you some examples of that. If I cycle the light to match the frequency of the vibration of the cord, it'll freeze it in time. Just like the images of the water droplet frozen in midair, for example. And we use these scopes to do this. Voice therapy, this is our team of voice therapists here at the University of Washington Medical Center and from Harborview. Our master's level, often PhD level clinicians who have a deep understanding of laryngeal physiology. They are not singing teachers. They are not diction specialists. They treat the behavioral aspects of voice disorders, and they're critical to the success of any large program. So we've looked down the throat. Now let's treat it. Here's a unfortunately common voice disorder. I believe this has sound. E. That's perfect. A little louder. Breathe in. Go back to a more normal pitch. So right here on his left vocal cord, remember we're looking down his throat, you're facing him. So there's left and this is right over here. The right is smooth, the left has a irregular, it's not a smooth mass, it's a lumpy, bumpy mass. That's unfortunately a vocal cord cancer. Now, every patient that is walking around that has an advanced stage cancer, they may have had their voice box removed or other sort of, big surgery to treat these, they all started as small tumors. You don't just start with a stage 4 tumor. So our hopes is we can identify and catch these patients early on when they're a little bit hoarse and treat them. He had laser surgery. Here's the tumor up close. Then we laser it out. And then here he is 6 months later.
Purposely in the right piriform so I can see.
So I show you a nice example. They're not all that great, but this is one of the common voice disorders we see. And laryngeal cancer, unfortunately, is the one solid tumor whose survival has unfortunately gone down over the last 10 years. There's no telethon for throat cancer. There's no walkathon. It is a very treatable. It's a disorder. It's a disorder which we can return patients to function, and I hope we make more and more strides in the future, particularly with the endoscopic surgery we're doing for that. I want to show you sort of a rogues gallery of lumps and bumps on the cords, which you may have heard of. People can get varices or varicose. You've heard of varicose veins. Varicosity is just an engorged or large blood vessel, and here is a tangle of blood vessels in the cord. When I play this video, you'll see this small instrument under the epithelium. Do you remember that layered vocal cord I showed you with the epithelium, the muscle deep and the 3 layers? I've made an incision in that epithelium. So we're operating down a tube a foot away with an instrument whose tip is 1 millimeter, and the epithelium itself is just a few cell layers thick. You can actually see through it. As I insinuate that in there, you can see that. You see that? So then we have to tease that out of there to preserve that voice, because I want this patient to sing that happy birthday. Now, this patient may not be a professional singer, etc., but our job is to give them the most capacity possible. This is a polyp of the vocal cord. This hangs off by a stalk. They're not all like this, but those of you who've seen or had a colonoscopy and heard of a colon polyp, it's a rounded mass. We're looking down the voice box, and here I'm using a laser, which is focused light, to cut off this polyp. The laser beam, the action is 0.2 millimeters, so it's 200 microns, and allows for very good precision at a distance, and allows me to operate a foot away, because I can't get these big hands down anybody's throat, but I can get them onto the ends of the microinstruments and the manipulator for the laser. A little too much char on this one, but we can get that cleaned up. and it comes off. And remember, that's about the size we're talking about. So we're sort of doing maybe a little cheek lift on Lincoln there. That's about the size of that. These are vocal nodules. Who gets vocal nodules? Huge generalization, number 18 of the night. 6-year-old boys and 25-year-old women, roughly. These are, we don't see a lot of males with vocal nodules. They have other things, but they're not vocal nodules. Vocal nodules are distinct from the other things I'll show you because, generally speaking, they're quite symmetric. They've got symmetry. They're thickenings. It's almost like that epithelium I showed you, that little thin, beautiful layer. It's turned into a shag rug. Okay? The cysts, which I'll show you next, the epithelium is okay, but there's an egg under the epithelium. It's like somebody's taken the carpet, pulled it up, and rolled a grapefruit under it. Okay? From a distance, it looks like a shag rug, right? If you're across the room, you just see a raise in the floor. But when you get up close, you realize the lining is smooth. That's a cyst. The nodule is the lining itself has become thickened. And we don't operate on these. These are the byproduct of vocal trauma. This is vocal abuse, misuse, and overuse. Okay? And so why do we not operate on these? Because they'll just do it again. Until they change the underlying behavior, there's not any benefit to operating on these patients. I don't do it. I've never operated on patient vocal nodules. People do it all the time. They sound great for a while. Then they're back in the voice therapy clinic or they're back in our clinic because they're having a rough voice again. This is the cyst. This is where, from a distance, it sort of looks like nodules. But let's focus on this still image here. From a distance, you can see bumps on both sides, but you get the sense there's something under this, and they're asymmetric. There's a boxer and there's a bag. So if I remove the boxer, the bag will settle down. This patient needs surgery. And we make a small incision and get into that layer and gently tease out that cyst. It takes 45 minutes to an hour to remove a 1 to 2 millimeter cyst from a vocal cord. It is tedious. Now this is a disorder called Reinkes Edema. Reinkes is the layer, that gelatinous layer that we've been talking about. That's Reinkes space. This patient, if you look at these, there's no other word than mud flaps. I'm not sure that's Latin, but these vocal cords, this patient has massive extra tissue under their lining. This happens to typically postmenopausal smokers. When I used to give this talk, I used to say postmenopausal female smokers until somebody told me that was redundant. So this can happen to men, but it's almost always, well, it's the vast majority of patients are women. Who does this person sound like? This is this lady sitting at the end of the bar. They've got the really heavy cords, and it's hard to blow the air past the cords. Okay? So what have I learned from operating these people? We don't operate unless they quit smoking, because if they don't care, I don't care. Now, if they have cancer, if they can't breathe, of course we take care of them. But if they're interested in vocal quality, which is not the most important thing in the world, but if that's what they're interested in, they have to demonstrate a commitment to vocal health, including cessation of tobacco use. There's no point operating on a smoker for vocal quality until they stop smoking. So the hard part is engaging that. And of all the things I do, being a small part of smoking cessation, honest to gosh, 15, 20 times a year, that's about the best thing I do, to be a small part of. I'm not pretending I'm any big part of that, but being a small part of that. So the problem with operating on these patients, it's very rewarding, but you can get into trouble if you overdo it. Guys, this is the person who's always getting asked on the phone, because the person on the other end of the phone can't tell if it's a male or female voice. Hello? Right? So if you overdo it, and the lady who's been hello for the last 20 years, the friends call them, hello? It doesn't go with them. They don't feel like it's them. They don't identify with that voice. So if you take them from hello to hello, they love it. Because they've moved up, they've dropped the effort, but they still feel they identify with the voice. So what I've learned over the years is don't overdo these patients. Leave them with a little bit of extra tissue, and they're more happy than if they have a high-pitched voice. Final one in the rogues gallery. of vocal lesions is papilloma. This is a disorder caused by HPV, the same culprit behind cervical cancer. And if you don't, I tell the residents this is probably not the best teaching in the world. I say, if you don't hate this disease, you don't understand this disease. Papilloma, I'll give you an example to summarize, or to bring it home. I have 3 patients who've had over 150 operations for this disease. It's a very, very devastating disease in some patients. It's a troublesome, I wish they didn't have a disease in most patients. But it can be a life-altering thing. It can be managed, but what it is, it's basically a wart of the vocal cord. And there is no predictable, reliable treatment other than surgery. There are some medications that can work. My hope is that this will change in the future with the advent of the HPV vaccine and its use in the next generation, and we won't see this disease again in 20 or 30 years. I hope not. One of the last things I wanted to talk about was what happens when vocal cords don't work. The lumps and bumps we showed you interfere with the vibration of the vocal fold. When there's growths on there, they're not going to vibrate well. But remember when we showed the picture of the nerve, here it is again, going down the neck and then curving back up to the voice box? If that nerve gets injured, then the vocal cords can't even get together to close. I have to show you this because normally people get vocal cord paralysis, people get vocal cord paralysis about half the time as a byproduct of surgery. Now remember, that nerve runs from the brain down the neck into the chest. It can happen after brain surgery, neck surgery, thyroid surgery, blood vessel surgery such as carotid surgery, or chest surgery. A lot of people can run into trouble with this nerve. It happens. It's not common for any given operation, but it happens. We see over 100 cases of this a year just in my clinic alone. Half the time it's from surgery. About 40% of the time, 37% in this small study, it's out of the blue. We think it's a virus. How many of you have ever heard of Bell's palsy? Okay, so the face stops working. See, those patients, a little easier to study, right? If you wake up hoarse, you don't sound quite right, you take some antibiotics, go see your doctor, et cetera, et cetera. But if you wake up and half your face doesn't move, you're in the doctor's office that day, by and large. It's hard to study these voice loss patients because a little bit of hoarseness happens to a lot of people. So it's hard to say when these things happen. We believe, we do not know, that this out of the blue or idiopathic, unknown cause voice loss is probably viral. And hopefully we can prove that over the next few years and have better treatment, but we have not done so yet. The rest of these vocal cord paralysis, weak vocal cords, damage to that nerve, happens from tumors in and around that nerve, and also miscellaneous causes, such as a nail gun. Wish I were kidding. And then this was amazing. I always get asked this by the medical students. One of the really key, important, valuable tests we have in medicine is looking at individual or small samples of small samples of tumor cells from needle aspiration. We take little needles and aspirate breast masses, thyroid masses, and the medical student invariably asks, can't you damage the nerve when you're sticking a needle around the thyroid? Because the vocal cord nerve runs right behind the thyroid. And of course, everyone always says, oh no, that never happens. Well, here's one. This is actually a lady, a very slender lady, a patient of mine I had, who said she was having her needle biopsy. This was when I was in Milwaukee. I was having a needle biopsy, and she became hoarse during the procedure. And I thought, something probably happened right about then, in fact. And then I asked for the slides, and there was the recurrent laryngeal nerve in the slide. They actually got the whole thing right in the slide. So it can happen, but this is supremely rare. So how do we treat it? It's really very elegant. When one of the vocal cords doesn't work, right, it's not doing its job to move to the midline, and I'll show you a video in a minute. What we do, I can't get it to move again, but I can put an implant in that sort of looks like a doorstop, and we put it in through the voice box cartilage to shore up that weak vocal cord. I did one this morning. It's very elegant, and the coolest thing about this operation is the patient is wide awake because we're talking to them because we want to tune their voice. We want to see how much we have to push on the vocal cord to give them a nice result. It's done under local anesthesia. The whole operation takes place in the size of a, I don't know, something about this big. But it's not a very big, major operation in terms of deep or it's just a little bit of numbing medicine will do it. And we tune their voice that way. Sometimes we have to put some extra stitches in there to tighten the vocal cords, but it's all done awake, so we can really monitor them and tune them. And it's a very rewarding operation for this. I'll show you an example. Here's a guy who lost his vocal cord function. The vocal cord is still there, but the electrical signal from the nerve isn't coming. You can see his left vocal cord, the one on your right-hand side, isn't moving.
Good. Can you do this for me? E. E. Okay.
It's sort of bowed and weak. And so
Claire?
after we treat it, same patient right about a month after the operation.
Good. A little higher. Keep it up. Keep it up.
He has the capacity to vibrate because we've put the vocal cords close enough together to work. Here is a opera singer
Big breath.
who did not have a paralyzed vocal cord, but had a slightly weak vocal cord.
Good. All right, new breath. Just a little
It's
bit lower pitch.
her right vocal cord.
Big breath, a little louder.
And she just doesn't have the range or emphasis or power that she used to. Do you see the black gap between the vocal cords? The cords can't meet.
Nasally, kind of
Doesn't
flat.
sound very abnormal for you and me,
Got you there, sorry.
but if you're an opera singer, she can't work.
New breath. Out the nose.
So she had the courage, after nothing else had worked, to undergo an operation. And here she is, a couple weeks post-op.
Yeah, there's a little bit of mucus there. Hit that note again, you can do it.
It's a subtle change. She still has a little gap, but it's improved.
She's there.
She didn't have that note
You
before.
better close your,
Yeah,
you weren't doing that before.
no, I wasn't.
A bit louder. Beautiful preservation of the wave, fantastic.
So we were able, by
Let's do that note
fixing the
again.
geometry, by getting the cords closer together, we could allow her vibratory capacity, the ability of those vocal cords to vibrate, to come back to be there. And finally, one of the cool things we can do, obligatory gory surgical picture, is in case for a younger patient, some of the younger patients don't want an implant. They don't want a piece of plastic in themselves for the next 40 years or whatever. We'll actually take a little bit of nerve from the neck to a muscle that doesn't need it and use it to sew into the voice box and do a reinnervation to restore nerve function. This is an elegant operation. Problem is it takes about a year to work. So somebody who doesn't want to be hoarse for that much longer, they usually choose the standard implant. But this operation is an elegant option to reanimate, not in terms of gross motion, but in terms of restoring muscle tone for these patients. So what we talked about was a review of how the voice worked, about how it has gross motion, the cords opening and closing, driven by that nerve. We talked about some of the maladies, the lumps and bumps in the cord, the paralysis that can occur. Talked about the tools we have for treating voice problems. We have to be careful with medications. We have to watch out for alcohol, tobacco, and caffeine. And then we talked about some of the treatments, including surgery, and we talked about the vocal cord implants, for example, that elegant implant we can do for patients with weak vocal cords. If you have any questions at all, please feel free to contact me here at the U. It's my privilege to be part of the medical community and part of the community. I grew up here. I had my tonsils out in this hospital, so pretty sure I'm the only one intending to say that. Thank you so much.